And with that, we'll turn to Michael Barr, who's an Executive Vice President at NCQA. Tell us what NCQA is doing. Michael?
Thank you, Mike. Thank you, Michael. Just want to make sure you can hear me all right, because it's the first time I'm in my office using my desktop stuff here. So can you hear me okay?
Gotcha.
Wonderful. Thanks for the invitation to join you today. Let me go to the next slide, if you will. I think most of you, if not all of you, are very familiar with NCQA, but I wanted to say what everybody else has said. You can't improve what you don't measure. So I'm glad to see we're aligned at least on that. We do everything in a very transparent manner in terms of how we develop our programs, how we develop our measures. And we like to hold entities, mostly health plans, but also practices and so on, accountable. And that's going to come back at the end of my presentation, because to move the measurement enterprise forward, you need accountability, but it's sort of a push and pull. And I think Sean said it also. We need folks using these programs and these measures. And I'm going to show you some data on the HEDIS depression measures set. And as Michael Schoenbaum said earlier, they're voluntary at this point. Some states are requiring them. We'd love to see others require them, because that's the start of this measurement-based care. I think folks are familiar with the impact of NCQA in terms of HEDIS reporting health plans, and millions of people are in accredited health plans. Can you move to the next slide, please? And we're starting to talk about this ecosystem of quality and trust. And this is just some of the programs NCQA has. We're aligning the programs to meet stakeholder needs. We're improving care, at the point of care, through care delivery. And that's where the recognition programs are. And we're working very hard to make sure, as HEDIS currently is, but also going forward, all the multiple data sources, electronic data sources used to populate measures for which we want to hold entities accountable, measure, and track. We need to validate the data, make sure the data are actually reflective of the care being provided, so we can get to performance, where we differentiate and transact. If you can click differentiate and allow folks to transact, if you can click or advance one, there you go. Now, you are not going to hear a specific program called measurement-based care from NCQA at this point. All of what we have is embedded and available through the health plan accreditation measures and a specific distinction program layered on top of the PCMH recognition program. And just to give you a sense of PCMH from NCQA's perspective, there are over 12,000 sites, recognized sites in NCQA's portfolio, with 43,000 unique physicians, something like 67,000 clinicians overall, and 303 sites have this behavioral health distinction for very many of the same reasons that Sean and others have said. There isn't an incentive to get it done. It's there, and you can hear a little bit more about it in the next slides. Next, please. Now, many of these themes have crossed over all these presentations, so I'll be very quick. Obviously, we need to identify people who need the care. We need to be able to provide best evidence, and that sometimes comes through the guidelines. Sometimes in the measures, people working towards measures, they adopt best practices to get better performance. We need to make sure that we're connected and handoffs are warm. Actually, I don't like handoffs because that sounds like a transfer. I like handshakes, although now with COVID, probably people aren't doing very many handshakes, but I think you get the idea that there's a warm transition of folks who need that specialty care. Obviously, adequately trained clinicians and teams. Not everything is just on the physician or clinician. We need teams who can take care of people as they encounter the health system. Talk about integrated treatment model, connected care, data sharing, very important, especially for some of these measures where you're tracking over time and people get the care in different facilities, different entities with different clinicians, and knowing how they're doing across is very important. And this gets to the next one is attribution and fair accountability. I mentioned this earlier. We need to know who's responsible for that care. We need to know that they're going to be accountable, and we need to hold them accountable, but we have to be transparent about how that accountability is applied. Several folks mentioned payment incentives, and we firmly believe as we look towards outcomes, there are still some very important structures and processes we need to have embedded because we know what good care looks like. We want to demonstrate that with the outcomes, but we also need to train and get practices and entities really doing what we know works best, and that's encouraged through measures of structure and process. Next slide, please. So I mentioned this behavioral health integration distinction program layered into the PCMH, so it's an option. It was developed in 2017. It's been available and has been updated since. There are 4 key competencies. It's building the workforce, information sharing and integration, using evidence-based care, and then measuring and monitoring what's happening. And that's, I think, where most of the measurement-based care that we've been talking about today fits. But I think all these other elements are really essential and critical and mentioned by other speakers. Next slide, please. Let's dive a little bit deeper. So these are the 4 competencies. You can see behavioral health workforce includes incorporating behavioral expertise in the practice and making those connections where you need some support outside the practice, and trains the team to really address the needs of the person and their extended network if necessary, but really focuses on the person. Evidence-based care, use and demonstration of use of evidence-based protocols and tools, and trying to address very specific needs, sharing that information where appropriate, supporting the integrated care, and then measuring and monitoring, utilizing the quality measurement, and then acting upon that to demonstrate improvement over time. Next slide. So what I've done is take just the top table shows the 4 competencies. NCQA develops its programs with core criteria and elective criteria. And you can see the numbers, 11 total core and 7 elective. And what that means is you cannot get this distinction unless you meet all of the core criteria. And I don't know the exact number of elective criteria, but you can't call yourself a distinguished behavioral health practice unless you meet all 11 core criteria. And if you click once, please, you can see at the bottom, there's behavioral health 15, 16, 17, 18. I've circled 15 and 16 because I think that's where most of what this group would call measurement-based care will fit, where there's monitoring and assessing symptoms over time for people with mental health or substance use condition and adjusting treatment plan if no improvement. And then the elective component to that is monitoring and assessing for both a mental health condition and a substance use disorder over time, and using tools. There are a variety of other requirements in the other criteria, as well as the competencies that speak about specific tools and some of those which we mentioned today. Go to the next slide. There are several HEDIS measures. As was mentioned previously, the depression suite, which is the first 3 measures, are currently voluntary. That is because NCQA does not hold health plans accountable for measures until a sufficient number of them can report a measure. That's been a challenge because of the data accessibility or lack thereof, specifically around PHQ-9s getting pulled out of charts. And health plans don't have ready access to that right now. Now, practices are collecting that data. They should be able to report it up to the data vendor and so on. So if you make it a requirement through your state programs, or you ask employers to make it a requirement of their contracts, you will see these measures get reported more often, obviously. I should point out that New York and Pennsylvania currently require Medicaid managed care organizations to report the depression suite. There are a few measures that are not here. Go to the next slide, please. The depression and postpartum follow-up ones. These are data as of 2019, the latest set of data that we have showing how few plans are currently able to report these measures. This is out of a denominator of 800 to 1,000 health plans. So I'm very encouraged by the conversation today. I hope you can see that NCQA has not been sitting on the sidelines. We're very active in this area. We want to pull in the same direction. We'd love to work with you and try and jumpstart or expand the reach of all of these programs, not just NCQAs, because this is an important issue. We're very committed to work with you on. And again, thank you for the invitation. I think I kept to 10 minutes, so back over to you, Michael.
Thank you so much, Michael. And we do look forward to watching what you're doing going forward. We appreciate the efforts to date. There's so much needs to be done.